are live. Your mic is hot.
Perfect.
You are on.
All right. Do you have the remote for me to click through slides, or? That's all right.
That works. Yep. There you go.
Perfect. Thank you so
Anything
much.
else you need?
No, we'll be fine. Thank you very much. Hello, everyone. I'm Dr. Christian Tschippert. It's nice to meet you all today. We're going to be doing acute coronary syndrome. So for you guys, that means chest pain. I mean, that's what the complaint is going to be and what you guys are going to run into. So we're going to cover just some basic pathophys on what is going on during ACS, kind of the spectrum of it. EKGs are really what we're going to hammer on for the back half of the lecture, and kind of what can be done en route. So there's different causes of that myocardial ischemia, because the ischemia is what's causing this discomfort. They're not getting oxygen to or through their coronary arteries to their heart for one reason or another, either due to supply or demand issues. So plaques, thrombus, or vasospasm. And the difference between plaques and thrombus would be, is it simply the plaque had been laid down, or do we now have blood collecting around there causing a clot? And vasospasm can occur somewhat more rarely, but if that's clamping down, we're now restricting blood flow for that reason. And then demand issues. Is this an arrhythmia going on? Are they in septic shock? Hypovolemia, hypotension. So for one reason or another, their body is at an increased load, and they're metabolically, that increased load is causing them to work harder, and their heart can't take that extra strain. So what differentiates stable versus unstable angina? Well, it's basically how consistent and predictable it is. So if you have stable angina, that is not necessarily ACS. It's predictable, but with rest, it should resolve. It's not necessarily a sign of impending damage. Now, where that changes is now we have chest pain plus or minus EKG changes, and we could have biomarkers elevated, but this is now at rest. It is not controlled. So this person at their minimum level of activity is still experiencing these symptoms. It jumps up to an NSTEMI when we have an actual elevation in markers that we can collect. So from the field, there's no real way that you guys are going to get those markers, but the suspicion is always there that you're suspicious that it's the most severe form until proven otherwise. And finally, the STEMI is where we can just look on the monitor and see the ST segments are up. So easier to notify a STEMI because it's just right there, but essentially we're always assuming that this chest pain could be a sign of damage. Same thing, stable versus unstable. Is it something that there's just the plaque within the arteries and there's nothing moving, it's just restricting flow, versus unstable? We now have a thrombus there. This is at risk of breaking off, and this is growing. This is causing more and more occlusion of that vessel. So when it's stable, this is not considered ACS. It's when we have unstable features or physiology that this is considered now acute coronary syndrome. All right. So plaque rupture with subtotal vessel occlusion. When you have a plaque within that vessel, it will likely change at some point. So we either have it breaking off, throwing a clot. This can lead to strokes. This can lead to PEs, or it just continues to grow and cause further occlusion. So the pattern becomes unpredictable. This is kind of the hallmark of unstable. Things have changed. It's no longer consistently relieved by rest. If it's lasting longer than 20 minutes, or we see those EKG changes, not just ST segment elevations. There's some other signs. There's also some chronic signs. So you can see signs of old infarcts or old damage that has occurred. And then again, the NSTEMI is simply the detection of actual biomarkers. So if there is significant occlusion to cause damage, that's where we have the actual movement to ACS. So just with those no elevations doesn't mean damage isn't occurring. It's just that it's not severe enough. And it's at the bottom. It's really undistinguishable from the outside. So all you guys are going to see chest pain. It's not controlled. It's still hurting right now. I've never had this before. All the things that they say. But from your perspective, treat it as an NSTEMI until proven otherwise. Or I guess treat it as a STEMI until you have a monitor saying it's not there. So when we get the EKG, well, we have the segments there. That's clear and obvious. We got a STEMI. If we have no elevation, but okay, we don't have the biomarkers yet, we can consider this an MI, just possibly an NSTEMI. If it's negative, then we lean more towards the unstable segment. At the bottom, Q-wave MIs, non-Q-wave MIs. stuff that's probably not going to be put on you as a burden, or at least from the outside. So it will be probably more from the ER perspective, but from the EKG that you guys get, that can give it useful information. So from the onset of these STEMI symptoms, you could have a slow progression, start to have T-wave elevations. The hyperacute T-waves kind of depends on the timing you get. Importantly, towards the end here, as you see these large UR segment kind of trenches is the right word. This could be signs of persistent long-term damage that has occurred, so a previous MI that's been there, and you'll have some persistent ST segment elevations that occur a lot of times with bundled branch blocks, or if somebody's a pacemaker in, their EKGs are going to be abnormal appearing, but this is now their new baseline. So what we always look for is at least one, I would say 2 is probably more apt, box elevations, so millimeter elevations, in continuous leads. If you have just one lead, a lot of times that's just air, placements can be different, people's anatomy can be different, so the electrical currents can be a bit different. So if I don't see at least 2 continuous leads having problems, I don't assume there's going to be a definitive diagnosis of ST segment elevation. You do. How much kind of training do you guys get on EKG interpretation as far as?
I mean, we have like cards that are given to us. MedFlight comes in and teaches us. We do the heaven criteria.
Okay.
So I mean, we get a lot of extra training on it, and we have a lot of things provided for us.
Okay.
We can continue to learn.
Fair. I all the time, if I'm consulting cardiology, they show me stuff that I have never seen or thought to look for. So it's a lot of information, and I try to nail the basics and kind of move up from there. But yeah, there's.
I'm from Kansas City, and when we first started putting up this protocol on recognizing STEMI in the field or whatever, we weren't able to transmit or anything like that, but we could call in the field. Pretty much whatever we read, and we were able to bypass the DNR.
And yeah, that's always helpful. So if you guys are calling us and saying, hey, we've got what looks like ST segment elevations from our monitor, it's much better for us to be like, all right, we need to get everything moving from the hospital perspective right away, as opposed to waiting until we get here and then realizing, okay, we delayed by so-and-so minutes. So yeah, if it's suspicious, I'm happy leading with that so we can be over-prepared. As far as ST segment depressions, this can occur in either reciprocal leads, so on the backside of an ST segment elevation. It can be a chronic finding, it can be a congenital finding as well. But when you have something that's upsloping, downsloping, or horizontal, the upsloping can be a slightly more positive sign. Downsloping horizontal can be slightly more, menacing. So there are a few conditions that the upsloping can be okay. Nonetheless, if it is in reciprocal leads, so if the other side is elevated, this is corroborating that we're having damage on the opposite side. So the location matters, and you just showed me the card, the basics. I never really liked it feels so weird to me to look at a card and just say, this is lateral, this is lateral, this. Yeah. So I try to, yeah. So I try to imagine the actual 3D imprint of like 1, 2, 3, 4, 5, 6, and then the person standing out, because it helps me visualize what areas are actually getting the change. I don't know why, just looking at that, it's easier. After a while, you get kind of better recognizing the basics, 2, 3 AVF being inferior in those ones, but for all the precordial, I tend to just imagine what it is. So if you have segments in a row, so we've got B4, 5, 6, there appear to be depressions there. And 2, 3 AVF, we have some minor depressions, some elevations AVR. So more than anything, it's more about the pattern overall. So what am I seeing across the whole spectrum versus just 1 or 2 leads? So, but if it's chest pain and they're saying this is occurring at rest, you're the same. You're getting the full chest pain workup, the whole ACS evaluation. And we just discussed this. So if you like it, you like it. It's the easiest way to remember. It works. I tended to not like it as much. Nonetheless, the big ones are the inferior, 2-3 AVF on the left side there. If that, you guys know the bad thing not to give.
On an inferior?
Yeah.
Uh,
Yeah, it's nitro. Just because it's preload dependent, so we want to make sure we're getting a lot of blood return to the heart. And morphine, so it's within like the old med school protocol. We'll talk about a little bit later. I never give morphine for specifically just because if they're like really hurting and I can tell that it's causing more stress in their heart just from being tachycardic, you can, but I mean, like 4 of morphine, I don't think is going to kill somebody. It's just
No, I thought it was, my understanding was more than really trying to have.
if we're I thought it was due to the decreased demand if you're lowering their pain. So the pain adds an extra like metabolic demand on the heart. Yeah, it could, but also what you're getting with the pain is you're getting valuable real-time feedback with the patient as far as is your pain still here? Is it getting worse or did it resolve? So all of a sudden they come sit down in bed and after 5 minutes they're like, my pain's gone. Well, is it because their heart demand dropped and now we have less ischemia and they're kind of on the up and up? Or is it because I just gave morphine and now it's masking all of that pain? So it may be getting worse, but the morphine's masking it. So I kind of like to have that real-time feedback with the patient. I know they're hurting, but if we lose some of that real-time feedback, I'm worried that we could go in a downward direction and I miss it just because they didn't. So that's kind of where I lean, as I hence not to be my go-to, but I understand the value of decreasing the demand of the heart just by dropping pain. So for posterior MIs, if you have depressions on the like 1, 2, 3, or V1, V2, and V3, you have those depressions. This could imply that you have a posterior MI, a STEMI, and it's just going negative on the front leads because it's on the opposite side. So you can actually strip those off, put them posterior to make V7, 8, 9, and it should, in theory, show elevations on those. I have yet to actually do that on anybody, but I'm sure cardiology would say, yeah, it's the most effective way to confirm. Yeah. What was the depressions? So inversions. So T-wave inversions are kind of all over the place. You can have some congenital reasons. You can have some old MI damage. You can have pacemakers change things. The important part is if they're continuous and if they're in leads that are upright. So 2 AVR and V1, that's pathological. So does that make sense? The leads that are upright. So yeah, T-waves, children can have them, persistent juvenile T patterns, bundle branch blocks, hypertrophy of the ventricles, PEs. I don't know if it would be the first thing I think of if I see that would be a PE, but it could cause it. So yeah, and lead 3 to normal variants compared to the other ones. So I tend to look for more obvious signs from the patient presenting clinically. As I'm having chest pain right now, this is new. Then I'm going with that as my suspicion as opposed to I feel fine, but I have these T-wave abnormalities and I have no prior EKG to compare to. I love when we have EKGs to compare to. Makes our lives easier. So, this normal? Yep. So, we don't like seeing those. So, until proven otherwise, this is bad. We need to evaluate for a STEMI, especially if you say, hey, I'm having chest pain. This is terrifying. Very easy. Call, hey, their SC segments are up. What about this? So, what are you seeing on it that looks abnormal?
I just lead one.
The lead one.
Look at
So we've got a little bit of an elevation 1. AVL looks like it has some ST segment elevations. Some slurring. Let's look here. So we have some, I would say, kind of minor depressions in 2, 3 AVF, more 3 in AVF, some elevations in 1 in AVL. So this could be a lateral MI. The subtlety of the depressions, yeah, I think 2 is kind of just a one box I wouldn't necessarily be super confident in that. But because 3 and AVF look a little bit more consistent and they're matching each other, that's a more complete pattern to me that we have.
If I looked at the whole thing, one is what brought me to it, two is the low baseline.
So for these, if I say we take out the AVL in one and I just have those depressions, it's still connected leads, it's posterior leads. And if the patient is presenting with ACS symptoms, I'm going with it. But if they're fine and I just look at this and I just saw some depressions of like one box, I'd be hesitant to call that until we have more evidence. If biomarkers are up, you can look at that. But so, yeah, exactly. So clinical picture to me is the utmost importance. EKGs, they help us, but they can be faulty. We put them on, we interpret them, so it's a prone to some error. Right. Does this one look normal or abnormal? You say V3 or 3?
It doesn't look normal.
Yeah. So this would actually be considered benign early repolarization. So you have this notch right here. I know it's not the highest quality, sorry about that, but so it comes down, really quickly comes up, and then has this little mountainous galley. So this can actually be okay. It's common to find in young, healthy male under 50, really strong hearts. You can have this early repolarization causing these weird elevations with that little J-point slurred notch. So if I'm seeing this in the field and they're having chest pain, I don't care about this condition. I'm still worried about it. But an asymptomatic patient who has this finding, this is one of the possible outcomes or possible explanations for it. Not normal. What could be causing it? That's exactly what I would think too. Yeah. Not really seeing, at least in the precordial, I'm not seeing great jumps from P waves there. I'm seeing a lot of ventricular work. So this is likely a left bundle block. So V1, 2, and 3, depressions, V4, 5, 6 can be okay. We still evaluate, but I'd say it's very common that we have patients come in, this is their EKG, and quickly look, yeah, they've got a history of a bundle block or they've got a pacemaker or something. But we also really like to see these very steep segments. So if this is this far elevated, we want this to be as long as possible. That's a reassuring sign. If that is short, if they're the same length, that's more concerning for something being acutely abnormal. What are we seeing here? Yeah, we had some weird kind of, I'd say fibrillation activity, 2, 3, AVF. How about the precordial, V3, 4, 5? How about the V3, V4, V5 leads?
Well, I don't really see the T waves at all.
T waves are peaked, kind of a weird angle to them. So this would be De Winter T waves. So peak T waves in the precordial leads, it is that upsloping. This is one of those times where the upsloping is actually bad, but having them in the V3, V4, and V5, indicative of an anterior STEMI, but it doesn't present on the EKG like quite a STEMI. Kind of a weird thing, but again, atypical EKG finding. Again, it's atypical. It's one of those where your EKG findings aren't necessarily traditionally what you define as like a STEMI. Nonetheless, this is one of those hyper-specific times where you're actually having damage. I think it's LAD, which is going to have the most damage here. But abnormal finding and abnormal EKG, but always go back to the patient. What am I struggling with? What's hurting? Chest pain? Yeah. Oh, well, gave that a 1. I already did it, so. And Welland syndrome. Biphasic T waves. So we have both an upslope and a downslope of the T waves in lead 2 and 3. So this is another one where it's bad. So inversion of the T waves, again, on their own, not bad. But when we have this biphasic coming upward and then back down, hard to see, but if it's in V2 and V3, has a logic. Is that anything important? This one, even I'm forgetting exactly. This one had a wild. Yeah, that's. All right, yeah. Yeah, so I'm seeing V2, 3, 3. Some weird kind of upslurring on the up towards the T waves. On lead 3, some depressions. AVF, maybe some. Yeah. So the reciprocal changes, like AVL, a little bump, V lead 3 is a little down. I also think AVF looks a little wonky, a little down. It's only 1 box on a lot of these, which I still don't find convincing enough. But because we have a 1 box up on one side, 1 box down on the other, it's more consistent of the story telling us we're having damage done. This upslurring I'm also concerned about, but it's the whole picture together that I look at. So you can never look at one lead and determine this is the problem. It's too inaccurate of a science. So I think there was just a bit of motion artifact, and AVL doesn't quite look consistent, but yeah, these ones I'd actually consider depressed. Like those are 2 boxes. It looks consistent between 2 and AVF for sure. 3 is a bit soft, but I have posterior leads. So De Winter's T waves, depressions within V2 through 6 with big peak T waves. So we're having these depressions here and these super tall T waves. This is indicative of a De Winter's T wave. So anterior MI, I still see the depressions in 2 and AVF, which those are the inferior ones. So it makes sense that if an inferior one is having negative changes, positive on the other side. So. All right. So what do we do in the field? This is where you guys, you know the kind of go-tos. I'm having this all of a sudden sharp chest pain. We can give them some aspirin. We try to get them to a facility that can handle their current presentation. So if you have a suspicion this is a STEMI, I mean, it's got to be to a PCI facility because we can't really do much else. If it's somewhat of an unstable angina, there's other measures we can do. But again, the goal is always we need to get them to a facility who can do the most important intervention. So, I mean, they can come to Freeman. It's always easy. Okay, perfect. Yeah, so do, and again, timing is everything. The quicker we can get an intervention done, the quicker we can either give medication or we can get in there surgically and open up that occlusion or blockage. That's what's going to save tissue. It saves cells from dying. It saves long-term damage for the patient, prolongs their life, and whatever quality they have with that. It's important about getting it as soon as possible. Worry about other stuff essentially later as far as how to manage those post-hospital or post-MI processes. You guys don't necessarily have to do that, but you do deal with the patients who had prior damage and are now requesting more EMS services. So we try to make sure that they don't have long-term damage if possible. So EKG changes, those are obvious. We know we got to get you to the hospital. Unstable angina becomes kind of a gray area, but again, you always assume it could be an NSTEMI or STEMI without other evidence. Your clinical gestalt, you guys see it. Trust your gut. Some don't feel right. That's it. And yeah, if we have delays in the PCI time, that just causes more damage. So if we can get there to a facility that has that capability within 60 minutes, or it's not going to take longer, push them out of the window, we need to get them there. So this kind of goes back to the morphine question. Modabash is what I was taught in med school as far as what to give: morphine, supplemental oxygen, nitro, ACE inhibitors, beta blockers, platelets, or antiplatelets, statins, and heparin. O2 is obvious to me. Just give supplemental oxygen because that's what they're lacking. Their heart's not getting enough oxygen. Easy. Morphine, pros and cons. Pros is it decreases the pain and decreases that metabolic demand on the heart, but it takes away that clinical response that I'm talking about. If you dampen their pain, they can't tell you necessarily, has it gotten worse, has it maintained, would it have gone away on its own? I don't know. Nitro. It certainly can help by lowering that preload. Just in inferior MIs, it's dangerous. So we need to not give it for the inferior MIs. So until you have evidence that it's not an inferior, we hold off. ACE inhibitors, beta blockers, that's stuff that's going to help long term, but not necessarily for you in the field. Yeah, statins, that's later stuff. Aspirin, yes. That's always a help to get that in the field if we have a suspicion. If they're not on it, give them it. If they said I've already taken it today and it was a full dose, that's one thing. Give aspirin. Do you guys have heparin with you?
No.
I didn't know.
Take a whole step
Yeah,
back.
yeah, true.
I've been discussed
Just do a
at
lot.
the medical control level many times, but for us right here locally in the Jasper, Newton County area,
Mhm.
I think a takeaway that thought is the transport time is usually short enough to not worry about it. That's usually been the sentiment that I've taken from those.
Okay. I mean, that makes sense to me, at least locally. Depending on how rural the patient's coming from, I could see that being other challenge, but
Clearly right here, some of our patients might be on the parking lot of the hospital. So, I mean, you could have that scenario versus the 45-ish minutes away. So
yeah. So
you got both, you know?
Yeah.
So it's like, they've been hesitant to hold on.
I can see why, but I also see that certain situations would arise where we're like, this is what's best for the patient, but
More rural drugs.
Yeah.
Ones in town.
what's best for the patient doesn't always get approved. So, nonetheless, yeah. And we talked about pain control. We talked about nitro, oxygen. Just give oxygen. I can't see a contraindication to giving the nasal cannula. And yeah, also asking about other medications they're on. They're on Viagra or a phosphodiesterase. This can be fatal. You can take them. I don't know why. For some reason, they like to withhold this information when asked, but I've seen it before. Have you guys ran into that where they tell you, no, I'm not on anything, and then 5 minutes later, hey, I got a confession to make? No.
I do have one more question.
Sure, yeah.
For withholding nitroglycerin on the inferior MI,
Yes.
then what would be your next step?
On that one specifically, nitro is out just because it can lead to their pressures tanking. It's not necessarily that there's another one to give in its place. It's just that that option is kind of taken off the table. If we're dealing with an occlusion or a thrombus specifically, it does help, but this kind of still depends on in the field or in the hospital. Are you asking? Sorry.
Patient outcome, even if you're thinning out the blood a little bit.
Yes. So you're. Yeah. So if it's a thrombus that's occurring, heparin's going to help because it's going to break up that thrombus. Problem is now we're running into the risk of bleeding in other aspects, which I guess we take that every time we give heparin. So in the field, the increased risk is there. I don't think it's necessarily thought of as a substitute for nitro. It's just the different mechanism. So I don't think of it as like this or that. I just think of nitro's off the table. Heparin is still here on the table as an option. It's just not related to the nitro.
Nobody really thinks of it in that way, especially in pre-hospital. But the paramedics that are out there, their first go-to is nitroglycerin. Now that's off the table.
Mm-hmm.
Morphine is give and take depending on which doctor or which cardiologist you're talking to, right?
Yeah.
And then,
So I know. So it's kind of like, what options do you guys have in the field that are available if we take off nitro?
it's just why not?
Yeah.
It's not any more dangerous than when they give it before they go to cath lab.
True. It's just in the field we have less options as far as other management. I kind of view it as I still need the patient to be them telling me that they're in pain. I know the nitro relieves some of that. Take the inferior portion off. I still want them to survive long term. So the more information they give me, including pain, is still helping us clinically. So if they're having pain, again, some morphine. If they're having just excruciating pain and the suspicion's high, you kind of take that into, okay, I have a high suspicion this is a STEMI or NSTEMI. We can give some to relieve pain, and we're still going to do the same stuff anyway. So there is kind of a give and take, and I'm sure if you ask other doctors, they're going to have a different perspective on, do I just want to control the pain, or do I need that pain there?
So our job in the field is to relieve not just the pain,
Mm-hmm.
but the damage that's being done.
Mm-hmm.
So them not having pain when you get to you
Mm-hmm.
is either good or just neutral.
If they're not having the pain, I know they got morphine. I'm still treating it all as they could still be having pain, which is fine. I mean, it's what it is. We're still going to run the biomarkers. We're still going to get lab work and EKGs and the whole cardiac workup on them. But it'll subtly change my trust in their presentation. So since I haven't been with EMS in person, I really don't want to like say how you guys have to deal with it, because I feel like that would be like me stepping on toes. Yeah, I just feel like it'd be me stepping on toes, like telling you something to do when I haven't had to deal with it. That just feels like it's wrong. So I would just say, if it's just nitro's off the table, I accept that they're just going to be in more pain. Is at least how I view it now. I know they're still in pain, but until we can get you to a place that's going to have like the PCI, the cardiology. Yeah, that is the most important issue.
That's my issue.
Mhm.
We need to stop that damage. Doesn't matter whether it's me, you, or cath lab,
Mhm.
or whatever. That damage needs to stop.
Mhm.
So whether it's me or you, that gets the damage slow down or stop before we get to cath lab. What would be the contraindication to actually doing that?
With the possibility of other bleeds if the patient is already on other medications, if they're super therapeutic on their warfarin, they didn't realize all of a sudden their INR is 4.5, 5, and because they just took it wrong or for whatever reason. So I mean, there could be others.
Test that you can run in the hospital that you would never have that information in the field, that's fine.
Mm-hmm.
Because our job is, yeah, we just gotta stop.
Yeah.
And I got 10 minutes to do it.
I would say if you're having a patient and their vitals are off the wall, so I mean, you're looking at a 180 heart rate, they're like, this is the worst pain of my life, it's excruciating, and you can't get a reasonable assessment due to pain, then managing pain could help you get a better clinical picture of what's going on. So it'd be kind of up to your clinical, whatever you feel is necessary. So again, I don't know what happens. Every patient's going to be different. So if you feel this patient needs something, I would lean on trusting your gut of your experience. And okay, we need to get some pain control to help with that. Is that kind of the area you're asking? Or I'm sorry if I missed it.
I'm just looking for, I mean, for years we didn't have to listen to this here.
Mhm.
And I was in here, wasn't the heart. I remember guys giving nitroglycerin to rule out.
Mhm.
Let's rule out whether this is a heart problem or not. Go ahead and give them the nitro. But it's become more protocol based now than it
Mhm.
was years ago. my thought process goes to whatever the problem is, if I can figure that out in the field, and I can alleviate it in the field.
And that's fair. At least as I've been brought up again, I'm new. So from my training, it's never give it for an inferior MI because of that risk of lowering preload too often, and that increases mortality rate. So because of the increased mortality rate, that's why we're cautioned to avoid it. So.
There's other options for us in the field. But they're not approved yet. Why would heparin not be approved? I understand you may increase the bleeding, but if it's biomarkers that you get from blood tests, then that would be perfectly fine by me.
I would say it's above my pay grade to make that call. I'm sure there's a legal medical liability component to why they're hesitant to do it for some reason or another. I don't know. I'm not sure. I'm not in those meetings, but just from my training, that's how we're kind of pushed towards. So, yeah. Is that fair enough? Sorry, I'm not giving you the best answer, but yeah. Yeah, fair. Oh yeah. So bottom right, there's torsades. I mean, there's plenty of arrhythmias that can go on besides just our regular VFib, VTAC. But these arrhythmias decrease the amount of blood we're actually pumping in circulation, so our heart's having less supply to it. It's likely getting a very high demand because if it's just fibrillating, this is constant contraction without efficiency. Cardiogenic shock, so depending on their heart failure state, if they have just a low EF to begin with, it's a lower threshold to push them into a situation where they can't perfuse. So, that is all I got for now. You guys have any other questions?
The stream is probably a little bit behind, 20 or so seconds behind. So let's give them
Okay, perfect.
even hear your question or your thing.
Yeah, fair enough.
The stream just not one black.
All right.
Okay.
So, I mean, at least as we see in the ER, it's a very straightforward, it is a chest pain, ACS rule out until proven otherwise. So as long as we come in with the story of it's chest pain, the description they give kind of helps us determine chest wall versus.
I think on a different end.
Yeah, that's fair.
I'll let you try to stop it.
Oh, sorry.
But there's something that we can do to improve patient outcome in the field before they get to the point. I don't see without any other contraindication why that would.
I would definitely assume for patients that are in rural areas and it's going to be an extended transport time before they can get to any type of intervention, that it would be very helpful to have that as an option. It's going to be, yeah, I assume just a medical legal liability on if they're determining if that's available. If there's one bad outcome and they say it wasn't within a hospital setting, I can see that being an issue. But as far as you guys having the option if needed, like there is no other option. We are, 2 hours out from any facility or whatever. I think it'd be a good option, but I'm sure there's stuff that I don't know that's why it's not accepted. But yeah.
I just come from that. I want to know why I'm not just.
That's fair enough.
I mean,
I don't know the exact logic behind theirs besides bleeding risk.
I want to know why I'm going to break the protocol, right? I can document it and go, this patient did not present this way, this patient did not. I didn't mix albuterol in it. I just didn't albuterol. It's fine.
Question for the board meetings. I wish I had a better answer, but no. Anybody have any questions in the?
Nothing online.
All right.
Thank you.
Perfect.